Hi, I'm Helen Bauer, and this is the Heart of Hospice Podcast. The Heart of Hospice Podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
Board-certified hospice and palliative medicine physician Dr. Alen Voskanian is my guest today, talking about advanced care planning, his work with hospice teams, and his antidote for compassion fatigue. Alen Voskanian is a practicing physician, a keynote speaker on healthcare leadership and wellness, and the medical director for Cedars-Sinai Medical Group. He's board-certified in family medicine as well as in hospice and palliative medicine. Alen served as an innovation advisor for the Center for Medicare and Medicaid Innovation, CMMI. He's also the author of Reclaiming the Joy of Medicine, Finding Purpose, Fulfillment, and Happiness in Today's Medical Industry. Alen is passionate about improving healthcare for all, and you're going to hear that in our conversation today. He's got a very interesting and unique hobby that we're going to be talking about at the beginning of the interview. After medical school, Alen chose to focus on working with HIV and AIDS patients. He's always been interested in working with people who have been marginalized. Dr. Voskanian was in Spain working with other doctors when he learned a term that was very enlightening. And you're going to hear us discuss this based on a post that he wrote. And he talks about why it was so impactful to him and how it's reflected in healthcare that we provide here in the U.S. today. He learned to write poetry during the pandemic as a way to practice self-care following his mother's death and to combat compassion fatigue. You can find Alen Voskanian's book, Reclaiming the Joy of Medicine, Finding Purpose, Fulfillment, and Happiness in Today's Medical Industry on Amazon and other major booksellers. I hope you enjoy this conversation. It's really awesome. There's a lot to learn. Alen, it's great to have you on the podcast. Welcome to the Heart of Hospice.
Thank you so much for having me.
I'm excited to have you. We've had other doctors on the show, other hospice doctors, but you have a unique gift, sort of a unique hobby, I think, for a doctor. And so I'm excited to have this conversation because that's the first question I'm going to ask you, is an icebreaker question about your hobby, which is performing stand-up comedy. How in the world? So you're a hospice doctor, you work with folks who are dying, and then you're doing stand-up comedy. How did you get into this?
Oh gosh. So I'll tell you how I got into it, but also now I feel pressure. I feel like I need to be funny.
You do. You do need to be funny.
Exactly. So I got into it actually because of hospice. When I got into hospice, I realized how how much people felt uncomfortable talking about end of life, talking about palliative care. And I thought, how awesome would it be to use comedy to address some of these serious topics in a way where people laugh about it, but you can also educate people. Also, I got into it as a coping mechanism. Sometimes when, they always say comedy is tragedy plus time. And when you can laugh about something, it helps you get over those strong emotions and feelings. So those were the main reasons. Also, one reason I got into it additional reason was because I was giving a lot of presentations in medical conferences. And I think if you've been to any medical conference, you know that most of the presentations are a little bit boring. They put people to sleep. And I thought it would be really good to add some humor because I realized when I was giving lectures and presentations, I was getting bored with my own voice. So I thought, okay, let me just spice it up a little bit, add more humor to it. So I got into it for those reasons. But then once I was in it, I just loved the camaraderie. I loved being around other comedians. When you are in a workshop with other comics and you're pitching each other jokes and adding kind of punchlines to each other's joke, there's just this sense of like the whole time stops and you're in it and you're laughing and you're helping each other. There's almost like a magical flow that happens, and I love that. I also really love the feeling right before getting on the stage, and also right when I leave the stage. It's just so amazing. I get goosebumps even talking about it. I love that.
I can tell you're very passionate about that. So, what topics do you talk about in your comedy routines, your stand-up sketches?
So I have three main areas that so far I've been talking about. Most of it really comes from my observations throughout the day. I often carry my phone or a little notebook, and if something annoys me or something I find like it's an observation of something that I find unusual, when I'm walking my dog and I see people like they interact with each other in a way that's to me comes across as odd. I keep thinking about that and I try to find the humor in it. For example, also when my mom passed away and I was at her funeral, I was just thinking about questions people ask. People were asking me about my mom or about how I was feeling. And I was just trying to focus on what is funny about this situation. And when you look around and you start observing, there's so much humor in day in, day out interactions, so many things that don't make sense. But my topics are related to medical issues. So some of the topics when I give a presentation, when I do comedy at a medical conference, it's really focused on medical humor about things that doctors do that is odd, things that just we all do when we interact with healthcare system. And then I talk a little bit about my experience as a parent raising kids. So that's an area that I focus on. And then the other part is about me being an immigrant. My last name, which most people have a hard time pronouncing, I talk about that and why I decided to shorten it to V. And partially why I went to medical school, because my last name is Voskanian. I decided to make it easier and shorten it to V, but V was too simple. And I thought if my last name was more elegant or more kind of more important, like Dr. V, that would be better. And because of that, I decided to go to medical school.
That was your motivation to go to medical school. Oh, I love
Yeah.
it. I love it. I love the idea of integrating humor and into the work that we do, because you can't make this stuff up. Real life, when it comes to working with people in healthcare and end of life situations, some of it is hilarious. It is just
Yeah.
hilarious. I love that you have so much passion for that, and that you bring it to your colleagues at conferences. I've been to those conferences. I've spoken at those conferences, and I think we could all use a little bit of humor when it comes to those talks and presentations that are given. So you're a board-certified hospice and palliative physician. I want to talk to you about how you started out working in that area, because most physicians move into that later on in their careers. How
Yeah.
did you get into end-of-life care, and, what captivated you about working with the dying?
Yeah. So I didn't start in hospice and palliative care after finishing my training. I actually finished my training in primary care, but decided to do a fellowship in HIV and AIDS. This is almost 25 years ago, which still like it's puzzling to me. How could it be so long ago? But when I came out from my residency, I really wanted to help patients impacted by HIV and AIDS. There were still a lot of young folks dying from it. I've always been attracted to helping communities that are marginalized or underserved. And I went into the field of HIV and AIDS thinking that death and dying was the enemy, and I was going to do everything I could to save my patients. Really like the field of HIV and AIDS. A lot of excitement was, a lot of exciting innovations were happening, new medications were coming out, and yet there were a group of folks that were dying because they were resistant to all the medications, even the new ones that were coming out. At that time, I was working in one of the only inpatient AIDS hospices in LA. And initially, when I was working in that unit, I wasn't very excited because I thought this is depressing, and a lot of people are dying, most of them young, most of them abandoned. Until one day, I cared for a young patient who was a musician. And we had a piano in the cafeteria. When he was able to move, he would always play the piano. He was a musician. But in the last few days of his life, his friends came, never left him alone. They were always one or two friends in his room, and they asked to move the piano to his room and kept playing the piano as he became unconscious. And he died surrounded with friends, surrounded with music, and in peace. And that changed my perspective about death and dying. I realized that so many people were dying in this really not peaceful ways. And I realized that as a physician and as a clinician, I could make a difference in people's life at the end. And that really motivated me. I became much less afraid of death and dying. And then all of a sudden, I realized that so many patients were feeling left out at the end of life, not only patients with AIDS, but cancer patients, end-stage cardiac patients. When patients would come towards the end, they felt that our main healthcare systems, their doctors that they had seen for many years, would wash off their hands and would say, "Okay, we're done. There's nothing else I can do. Go to hospice."
Right.
And because I've always been attracted to helping people who are kind of on the fringes or left out from our healthcare system, I was like, this is great. Palliative care, hospice, this is a field where we can take care of patients, just live better lives at the end. So I did a career pivot, became board certified in hospice and palliative care, and just found this renewed joy for healthcare.
That's wonderful. How many years had you already been working as a physician when you went back and became board certified?
About 5 years.
About 5 years in.
Yeah.
That's some
For
amazing
5 years, yeah, for 5 years, I did HIV work. Then I did hospice work, but I wasn't certified. And then finally, I decided to become board certified.
That's awesome. That's awesome. Board certified hospice physicians are so integral and so crucial to the work of interdisciplinary teams. It's amazing. I think one thing I'd like to mention is, for my listeners that aren't familiar with this, when it comes to the roles of a hospice doctor, a hospice medical director, one of the big things that they do is educate the team. They teach the team, and it's built into the work that they do and the meetings that they have and the conversations, the IDT meetings that take place every couple of weeks. So that, yeah, it's a big part of what they do. I have learned at the hand of so many great hospice docs. But I think people may not realize that. If you don't work on an end-of-life team, you may not realize that those hospice medical directors are also teaching the teams. Even though it's not a hierarchy, everybody has an equal voice, but that's one of the special roles of a physician on an interdisciplinary team.
I would also say it's reciprocal. I feel like I learned so much during those team meetings from nurses, especially when it came to compassion, empathy, being present in a very challenging situation with patients, with family members, and being present in the room, in listening, even in pain management. Some of the best teachers and mentors for me in pain management and wound management, taking care of wounds, were nurses. So I feel so grateful that I had the privilege of learning from so many nurses in those IDT, those interdisciplinary team meetings.
Yeah, there's a lot of opportunity. We definitely learn from each other. And that's one of the reasons that team structure is so powerful. It's because everybody brings a specific skill and we learn from each other.
Right. Yeah, even social worker and chaplain, I think most people don't realize that how the hospice teams are kind of organized. And I remember when I was very kind of new to the field, I intentionally chose a chaplain who he has since passed away, but he was just so kind and so gentle. In every challenging situation, he would volunteer, he would go in, and he had this magical way of bringing peace to challenging situations. So I intentionally would follow him and do home visits with him, and would observe his magic and what he was able to do. So yeah, I think the learning aspect of that hospice team is just really unique and very special.
Yeah, it's one of the strengths, I think, of the teams that we work with. Absolutely. So you had mentioned advanced care planning, and I want to talk about an article that you wrote on LinkedIn. It's how you and I got connected. You wrote something called "The Moment I Learned What Medicine Gets Wrong." And it caught my eye just from the title, and I read the whole thing. I would love it if we could talk about that experience. Was during your intern year, you were early in things. And can you tell the story of that experience and what happened?
Yeah, I think this experience, and since I wrote that article, so many people have reached out to me, sharing that they have felt the same way that I did as an intern, and they still continue. So that part is not good, that because I was an intern 25 years ago, and I remember during my ICU and internal medicine inpatient rotation, so many patients were coming in, elderly patients, being intubated, had tubes from every single orifice you can imagine, and being dialyzed on respirators. And no one was having crucial conversation with the families, and just explaining the chances of surviving that hospitalization. And and that was really bothersome to me. I just was like, why is this happening? And one thing that was also being taught, like tacitly, like you would learn from other residents and other interns that, oh yeah, this is like not the right thing to do, but this is the doctor. He or she always like dialyzes patients, or he or she always intubates, even when there's no chance of like being coming off the ventilator. And they would say like, hey, don't say anything. This is the way this doctor does it. And that just felt so wrong to me. And, I realized that when you are able to communicate with family members, tell them about just all the risks, all the benefits, um, and how, their loved one could have a better quality in the remaining parts of their life without being in the hospital. Um, you know, People like having that choice for themselves, for their loved ones. And when you engage them in that discussion and explain to them in clear terms what are the benefits of getting certain tubes, then they are able to make a choice. And often those choices are more aligned with their long-term goals. They can be at peace in their remaining time, and shifting this focus from just quantity to quality, which is how many more days can someone survive versus how well can they live till they take their last breath. So I think I learned that in internship, and that always stayed with me. And when I saw this field of palliative care growing, I was like, okay, this is what I felt as an intern. Now I feel like I can be part of this. My experience in the uh, working and having the privilege of being at the bedside of so many HIV positive patients dying, just my vision, my why for healthcare became very clear to me. But I think the article you're referring to is when I was in Spain a few months ago. We were talking about end of life care in Spain, and one physician used this term that I'd never heard before. She said therapeutic cruelty. And I thought about that. I'm like, that makes sense. And she said that when they see therapeutic cruelty happening in their hospitals, they're not afraid to call that out to other doctors. And they're not afraid to bring that up to patients. So I was like, wow, that's exactly what I was seeing during internship. So, yeah, I think that's why we connected originally.
Yeah. So do you think that's the same term or the same implication as medical futility?
Yeah, I think it's very similar. I think therapeutic cruelty, maybe it's a little bit puts the blame on us as people who are doing it. I think therapeutic futility or just medical futility is less focused on the doer. It's more focused on the intervention or the action of what's happening.
Right.
So it's similar in some ways.
So for my listeners, just to talk a little bit about what these terms mean, when we talk about medical futility, basically what that means is the intervention that's being provided is going to be futile. It's not going to have a benefit. It's not going to get the desired result. It's a useless treatment that doesn't really have a chance of success. Therapeutic cruelty, I agree. It sounds like I don't want to use the word blame, I guess, but the responsibility of it, yeah. Right? The ownership of that is coming from the healthcare provider. And it's interesting because the words are at odds with each other. It's intended to be therapeutic, but it's not. It's cruel. Yeah. It's cruel.
Yeah.
And we do this a lot in the United States. We overtreat with things that aren't going to be successful. I don't know what the statistics are, but there have been several studies published and statistics published about the amount of money that's spent on people at end of life, especially with Alzheimer's and dementia diagnoses. And
Yeah,
it's a huge part of what's spent in the United States for healthcare
right.
needs.
Yeah, yeah, yeah. It's really puzzling, and the reason why every chance I get to travel to another country to learn about their healthcare system, I take that chance because I want to learn about why we in the US spend twice as much on healthcare. Almost close to 20% of our GDP is spent on healthcare compared to other countries in Europe, other developed countries like Spain. They spend about 10%, and they have some healthcare outcomes that are better than us. Their longevity, how long people live, is better. And it's like, how can it be that we spend so much more money, but we don't get as good of outcome? I think there's a lot of debate around that, but I think at the end of the day, there's like a lot of great lessons to learn by studying other countries.
I agree. I mean, it's interesting. We know that so many people across the United States say they don't want to die in a hospital, and
Yeah,
yet so many of them do. They want to
right,
die outside in their own homes.
right.
Yeah. Yeah, we never can seem to get that quite right.
Yeah. And there are people, I mean, there are definitely, I think being in hospice, I would definitely say that there are people that for their sake, their family's sake, like hospital or a nursing home is the right place for them to die. And
Sure.
it's really about giving choice. I think what really frustrates me and is very upsetting to me is when patients and their families don't get a choice. Like they don't know what options they have, and they end up in a situation where if people had given them a choice, they would have made a very different choice. Like that should never happen. People should be in charge. They should know all their choices, all the options, and that is not okay.
Yeah, I agree. So you've been doing this for a while. You've been working with seriously ill patients, even before you worked in hospice, right? Because you were working with
Yeah.
HIV and AIDS patients. Tell me about a time when you were inspired by a patient or a caregiver.
Gosh, there's so many stories of inspiration, and I think some of it, I like this one story comes to mind that I've heard similar stories, and obviously the stories that I always remember are when the patients are similar to my age, and I remember that there was a young gentleman in his 40s, had 3 kids, and they were all young. And I met him. He had end-stage brain cancer. It was summertime, and I often ask my patients about what are their hopes and what can I do to help them. And his hope was to be able to celebrate one more Christmas with his young children, because he thought that they were going to remember that, and he wanted to be there. And it was sad because we all knew that he was not going to be able to stay alive till December, but we were able to, celebrate Christmas in summer, and it was, for the kids, it was one more Christmas that they celebrated. I learned very quickly that it's really hard to find a Christmas tree during summer, but his kind of clarity on what he wanted to do, on like living this memory with his children, was inspiring to me. And I think I think those of us who work in hospice, it's so easy to think about like our own mortality and our own, like, how would I deal with this if I was in this situation? Or when I talk to parents who were losing their children, like those always were the most challenging scenarios for me. And I always like would say, okay, how would I deal with this if my child was um, terminal? And um, so those scenarios were always very inspiring to me because they showed me that even in the most challenging of times, human resilience, like learning from other people. For me, this 40-year-old gentleman who was able to celebrate one more Christmas with his family, like I was like, okay, that's others can do that. He did it, and I'll be able to do something like that. It was just a hope about humanity and our strength, who we are as human beings.
I love that. Do you find that as you got older and you were taking care of patients that were your age or younger, did you find that that affected you differently than caring for older patients?
Oh yeah, definitely. I think, and there's always like even older patients because my parents were alive at that time, and I would then connected with my parents too. So it did impact me differently. I was like, oh God, like this could be my mom, this could be my dad, and
Right.
going through this situation. And I know people always say like you shouldn't, there's transference and countertransference and all these things, but to me, one of the ways I found to maintain humanity, to maintain compassion in healthcare, is to always think about like how I would want my family members or me to be treated. And when I work with other doctors and nurses, and I always tell them like, hey, this is somebody's mom, this is somebody's dad, and they're at their worst right now. They're not feeling well, they're upset, and they have a reason to be. And if this was my mom, how would I want them to be treated? So I think I always try to find a way to humanize my patients. And when they're young, when I was young and they were my age, that connection would humanize them. And when I work with patients who are older than me, I always connect with them by thinking of them as people that I care about. So
I think every death is relatable
yeah,
because it's another human being. And you're right, we do try to sort of dehumanize it
yeah,
because it makes it easier for us to move through the day and do the work when it gets really
yeah,
difficult. But every death is relatable on some level because it's just another human being.
right,
Yeah,
right.
yeah,
Yeah, and it's a balance. It's a balance because if you're humanizing it too much and you can't take care of the patient, then you're not doing your job right too. So how do
right.
you find the balance of uh, being able to do your job and take care of somebody, yet also see them as a human being? And also when after someone dies, like how do you recover from that? And for me, the hospice, the team was the way we would recover from it because we would come the following week and we would share like how we feel about what happened, um, remember the person, honor them, and I think for me that was really healing because otherwise it can get overwhelming.
Yeah. So for listeners, just part of the interdisciplinary team meetings, when we meet every other week or so, we talk about the deaths that have happened since the last meeting. And for a lot of teams, it's very therapeutic to talk about the death, talk about the patient and how that was meaningful. And a lot of times teams will have some sort of ritual. I had a team that had a bowl, and they started at the beginning of the year, and they would add a stone into the bowl for each patient as the patient died. And that was how they honored the patients. I've seen other teams that lit candles in IDT when they were discussing a patient that had passed away, and just a lot of meaning in that. So,
Yeah.
Alen, the next thing I wanted to talk about is really related to what you had just mentioned. So this is a great transition into this topic, compassion fatigue. We have a tendency, I think, in hospice to think that we are having more contact at the bedside as nurses and social workers and aides and chaplains and volunteers than the physician does. And so the physician really shouldn't be dealing with compassion fatigue. But when in fact they certainly are. How has compassion fatigue affected your work?
Yeah, I think for me personally, having people that I can talk to is a great source of kind of dealing with compassion fatigue, or just being able to have someone who can listen to me. And I think the challenging part is that sometimes I also don't want to overburden someone else who's going through that. So if there's an IDT, let's say, interdisciplinary team, and I know that the nurse was very close with the patient and the social worker, and they were very involved, and I maybe was seeing the patient once a month, and I feel like they're going through it, I wanted to be there to support them. But also I was feeling it. So I didn't feel like it would be good for me to kind of share my maybe sadness or sorrow or whatever I was going through. So I would sometimes share it with my husband or some family member or a friend, where I felt like I could release and process what had happened. I think this actually happened to me when my mom passed away unexpectedly during the pandemic. And I was just so devastated and going through the grief. And then I had to pause, because my mom also was a very big part of my three sons' life. And she helped raise them, and my kids were also suffering. And I realized that like I had to stop my grief and what I was going through, because I needed to be there for my children. And I'm not saying that was the right approach, but I realized that like I needed to be there for my family. And I think that's the same way sometimes I felt as a physician on a team, where I needed to be there to support my team members. But we also, as physicians, we do need a source, somebody to go to and be able to process our thoughts. And, I often found people that are more removed from hospice, like friends who are not in healthcare, have served that role for me. And usually I think we all have somebody who is just great listener, who can just listen, not try to solve or fix the situation. Sometimes it's just, if you have someone in your life that just can listen to you, that has been very effective for me.
That's wonderful. That's really a great idea for anybody who works with patients who are at end of life. And the thing about having somebody who listens and doesn't try to fix, that's brilliant, because they're not going to fix your grief.
Yeah.
And grief doesn't need to be fixed.
Right.
But to offload it a little bit, so that you're sharing that heaviness, that weight with someone else.
Yeah.
I think that's a wonderful thing to have. And I'm sorry that doctors aren't typically most hospice teams don't have their doctors in the office every day. So there's not that ongoing support. I love it that you find people to talk to. You realize how important that is for you. That's great.
Yeah. Yeah. And I think during the pandemic, I think the grieving process was so impacted, because so many people, including me, did not have people that we could meet and go through the rituals of grief and bereavement. And one thing that I found during the pandemic was writing. So while on the outside I was grieving or not trying to show that I was going through that process, trying to be strong, but I found a writing community focused on bereavement. And, I got introduced to poetry and started writing poetry. And I found it so therapeutic. I'd never experienced that before, and just can like brought out this sense of joy from poetry. I I love it. I love writing poetry. I wish I had done it when I was younger, but when I was in preparing for medical school, I was such a type A person. I was only taking like pre-med classes. I didn't really venture into poetry, but now that I'm older, I do poetry and I do stand up because I feel like um, I missed out on those things when I was younger.
But those are some great self-care
Yeah,
habits for you to have. I think that's wonderful. And it's the creativity. That's so
right.
healthy, so healthy.
Yeah,
So you have since moved into administrative and leadership roles. You do a lot of
yeah.
education, a lot of writing and speaking. What do you miss most about bedside care?
You know, I don't say I miss it. I don't. I'm still in seeing patients once a week. I see patients, so I that's why I knew I would miss it if I gave up seeing patients, and I don't think I'm ever going to give up seeing patients. I'm I chose to become a doctor. I love being a doctor. I just have so much joy and just respect for this profession that I will try to see patients as long as I can, and as long as I feel like I'm doing a good job taking care of my patients. So I still see patients half a day a week. I do miss hospice and palliative care. I miss it a lot. The work I do is more outpatient. It's not end of life care. So I actually, that was something that I kind of put on my one of my goals is to get back in hospice and palliative care, not to work full time, but just to be able to round with a team maybe once a month to just get back in the field because I just it's so fulfilling to me, so gratifying. So I miss that part. But the reason why I transitioned to leadership is because I saw so many doctors and nurses are burnt out and um, unhappy in healthcare. And the reason why I went into healthcare is to help people, help patients. And I think doctors and nurses only can help patients when they have that sense of joy, that sense of purpose. And I realized our healthcare system is so broken, and I wanted to be in leadership so I can be involved in fixing it and helping other clinicians help their patients better.
Well, so you have written a book, um,
Yeah.
Reclaiming the Joy of Medicine, Finding Purpose, Fulfillment, and Happiness in Today's Medical Industry. Tell me about the book and who it's for.
The book is for other clinicians or family members of doctors and nurses, also students who want to go in healthcare. I wrote this book during the pandemic when I was kind of coping with my loss of my mom. I signed up for a program at Harvard Medical School for writing, and I was writing every day, focused on physician wellness and physician burnout. Then, also at that time, we were all kind of feeling lonely. So I started calling some of my medical school friends, asking them how they're doing. And not surprisingly, so many of them shared their burnout, their sense of frustration with healthcare. So as I was writing about it, I thought, okay, let me just explore this more. Let me write about it, and that's how that book. That's how I wrote that book. So
It's so important. Alen,
yeah,
the work that you're doing and the voice that you have in the end of life community is so valuable. And I will tell you, as a nurse, I'm so grateful for what you're doing and how you're supporting your team members and the value that you place on all of these other disciplines. Where can listeners find a copy of your book and purchase it?
um, thank you for that. It's on Amazon, Barnes and Nobles, and just all the major booksellers. So it's called Reclaiming the Joy of Medicine. And yeah, and please reach out to me after you read it, give me feedback. It was my effort to write something. And at the end of the book, I share some things that have helped me, and currently I practice to stay um, happy in healthcare and to have joy in the field. And again, like when people ask me, would you go back to medicine? Would you recommend your kids go into healthcare? My answer is always definitely 100% yes. I think it's one of the best field. It's such an honor and privilege to help other people at a time in their life when they're not feeling well. So I would go back to medicine 100%.
I love it. Alen, it's been a privilege to have you here on the show today. I got to tell you, do you have a joke that you want to share before we close? This is your chance, man.
Okay. So I think our healthcare system is so messed up. It's like you go into the hospital to feel better. You come out with things that you do not want and you do not need. It's almost like going to Costco. Um, my neighbor Joe, he's 80. He fell and broke his hip. He was hospitalized. He was there for a couple of months. He came out with urinary tract infection, a blood clot, and a cute newborn baby girl.
I love it. Anybody who has ever been to Costco will totally get that joke.
I hope the listeners find it funny.
It communicates, definitely
Yeah.
communicates. Keep finding the joy, Alen, and sharing it with everybody, and keep doing the work that you're doing. Your voice is so valuable, and thanks for being on the show.
Thank you so much, Helen. It was such a pleasure.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.